What's up, everyone? It's Miles here from bootcamp.com, and today in pulmonology, we're going to be going over pneumothorax. So before we begin, let's just remind ourselves of a few basic concepts. So first of all, let's just draw in a lung right here. We know that the lung is covered by our pleural layer, and the pleura is attached to the lung interiorly, and just outside the pleura, we have our chest wall. And of course, as we know, the lungs have a lot of elastic tissue, and so they have a natural tendency to collapse inwards. And the chest wall is more springy, and it has a natural tendency to expand outwards. And the pleural space that lies in between the lungs and the chest wall is a fluid-filled space, and it's essentially acting as a liquid layer that's holding the lungs and the chest wall in place. It's kind of like two glass slides. When you put water in between them and you try to pull them apart, it's very difficult because that liquid layer in between the two glass slides. Now, of course, we also know that there's air within the lungs, and there's also air just outside the chest wall in the environment. Now, if for some reason the lungs become ruptured or the chest wall becomes ruptured, we can introduce some air into the pleural space. And as air enters the pleural space, it's going to essentially start to dissect that liquid layer of the pleural space, and that's going to abolish the connection between the lungs and the chest wall. Going back to the glass slides example, when the two glass slides are being held together by a liquid layer of water, if you introduce some air in between the glass slides, that's going to cause them to easily come apart. And so I just sketched in the end result over here. If we have air that has entered and dissected the pleural space, now the lungs are essentially no longer connected to the chest wall via that liquid layer of the pleural space. And now because the lungs are no longer connected to the chest wall, it's free to collapse down to a smaller volume as shown. And this really illustrates the basic concepts behind what's happening in a pneumothorax. So a lot of people equate pneumothorax to the collapse of the lungs, and this is to some degree true, but the more accurate definition of a pneumothorax is air accumulation within the pleural space. And like we just described, when you have air accumulation in the pleural space, you're going to be abolishing the connection between the lungs and the chest wall, and as a result, the lung will collapse. So when this happens, the patient will classically present with a sudden onset dyspnea. So this is not something that occurs over weeks. This is something that occurs very suddenly, and it's accompanied by chest pain. And so you should be adding pneumothorax to your differential diagnosis of a patient that presents with acute onset dyspnea and chest pain. Just to name a few others, of course, there are things like myocardial infarction, pulmonary embolism, things like panic attacks, and there are others. And so when you have conditions like this that all initially present very similarly, like acute onset dyspnea and chest pain, oftentimes they're all going to be included together as different answer choices in the same question. And so as a result, you need to be able to differentiate between them on board exams using clues in the question stem, such as imaging, labs, ECG, or history. So moving on, there are two main ways that you can get a pneumothorax. The first one, which we're going to talk about, is a spontaneous pneumothorax, and the second one that we're going to talk about is a tension pneumothorax. So let's begin by talking about the spontaneous pneumothorax. So a spontaneous pneumothorax is classically caused by the rupture of something called a subpleural bleb. So as the name suggests, it's subpleural, so it's underneath the pleura, hence the lungs, and what it is essentially a local defect that occurs in the lungs that causes just a little portion of the lungs to balloon out. So one of the ways that I like to think about it is like when you're blowing up a tire and you accidentally put in too much air, and then you have this local portion of the tire that has this little defect where it kind of balloons outwards. So if you can imagine, there is a little bubble that has formed on the lungs just underneath the pleura, and then after a given amount of time, that bubble may burst. And when it bursts, we're going to see air rushing from the lungs into the pleural space. And like we mentioned, as the air goes into the pleural space, it's going to abolish that liquid connection between the lungs and the chest wall. And as a result, we're going to see the lungs collapse. And of course, as air enters the pleural space will expand with air. So if we just take a look at this diagram, this right here represents a bleb that has formed on the lung surface. And then after a while, it may burst. And when it bursts, it's going to introduce air from the lungs into the pleural space. And as a result, the pleural space is going to expand as it fills with air, and furthermore, the lungs are going to collapse. Now, it's just to note that when you have the rupture of a subpleural bleb, the hole that's created from the rupture is essentially large enough to allow air to flow from the lungs to the pleural space, but also from the pleural space back into the lungs. And so now the lung chamber and the pleural space chamber are essentially connected by free-flowing air. And so as a result, the pleural pressure and the alveolar pressure equilibrate with each other. So we'll just write that here. For a spontaneous pneumothorax, the pleural pressure is equal to the alveolar pressure. Okay, so the classic risk factors for a spontaneous pneumothorax are tall, thin males, and this is especially true in Marfan's patients who are, of course, usually tall and thin. It doesn't have to be a Marfan's patient, but it's frequently reported in Marfan syndrome. And so they'll usually give this to you in the question stem. They'll say that the height is something like 6'4" or 6'5", and maybe that they are a smoker, and now all of a sudden they have acute onset dyspnea and chest pain. You should definitely be considering spontaneous pneumothorax from a ruptured subpleural bleb. Okay, so now let's move on to the second type of pneumothorax, which is called a tension pneumothorax. So what's occurring in a tension pneumothorax is we're getting the progressive buildup of air in the pleural space. And this classically occurs following trauma when we get the formation of a unidirectional valve. And this classically occurs following trauma either to the parietal pleura on the outside or from the lungs on the inside. And this trauma is going to result in the puncture of one of these layers. And the puncture occurs in such a way that we get this formation of a unidirectional valve. So just taking a look at this diagram here, we can see that we can either have a puncture wound to the lung itself or a puncture wound to the parietal pleura. And if we were to zoom in on the actual wound, we can see that the puncture occurred in such a way that it formed this weird flap that only allows the unidirectional movement of air. So we can see that this black line here represents that unidirectional flap wound that has formed, and we can see that air can go from the lungs into the pleural space, but if that air were to return, it would close the flap and the air wouldn't be allowed back from the pleural space into the lungs. And similarly, we can see the same thing happen down here where we get the formation of a unidirectional flap on the parietal pleura, usually due to something like chest wall trauma, where air can move from the atmosphere into the pleural space, but it would not be able to return because upon return, that flap would close. So the whole idea here is that after trauma, we get the formation of this unidirectional flap or unidirectional valve, and air can enter into the pleural space, but it cannot escape. And so every breath, we're introducing air into the pleural space, and this is going to progressively increase the pressure of the pleural space with every breath. And so as a result, as we keep introducing air into the pleural space with every breath, that pleural pressure is going to get very large. And so that's why we call it a tension pneumothorax, because we're building up a lot of tension in the pleural space. And so this is one of the main differences between a tension pneumothorax and a spontaneous pneumothorax, because in a tension pneumothorax, the pleural pressure is getting very large, whereas the alveolar pressure is essentially staying stagnant. And so we can write this down here. In the tension pneumothorax, the pleural pressure is going to be much larger than the alveolar pressure. And another classic finding of a tension pneumothorax is as we keep progressively building up pressure in the pleural space, this half of the thorax is going to have a very high pressure. And so as a result, it's going to push everything to the opposite side of the thorax. And a very classic finding is we are going to have the trachea being pushed away from that high pressure. And so we say the trachea is deviated away from the side of a tension pneumothorax. Furthermore, it's not as high yield, but we can also see things like the heart starting to be pushed away from the side of the pneumothorax as well. And lastly, recall that we also have the inferior vena cava and the superior vena cava running through this region as well. And because these are veins, they're very thin-walled and they are susceptible to collapse. And so when we have very high thoracic pressures, like in the case of a tension pneumothorax, these vessels are susceptible to becoming collapsed. And so as a result, we can start to see venous blood backing up, which will show up as increased jugular venous pressure. And furthermore, because we're not returning blood to the heart as much anymore, this can also show up as hypotension and shock. Okay, so now let's just go over a couple classic scenarios. So the first is going to be a fractured rib. And what happens here is the sharp fractured rib pieces kind of turn inwards and puncture the lung tissue. And so we usually see air flowing from the lungs into the pleural space. And furthermore, we can also see this with chest wall penetration or chest wall trauma, where we get the puncture of the parietal pleura. And so in this case, we'll see air flowing from the atmosphere into the pleural space. So like we mentioned, the hallmark of a tension pneumothorax is that we're going to see the buildup of positive pressure in the pleural space. And this is really due to that unidirectional valve that has formed because of trauma. And like we mentioned, some associated findings that occur when you have the progressive buildup of positive pressure in the thorax is going to be things like tracheal shift, and the trachea is going to shift away from the affected side. And furthermore, we can see the collapse of the superior and inferior vena cava, usually the superior vena cava, and this is going to result in a decrease of the venous return, which can result in things like hypotension, tachycardia, and increased jugular venous pressure. Okay, so now let's mention a couple classic physical exam findings that occur with both the spontaneous and the tension pneumothorax. So like we mentioned in the lung physical exam video, when you have a lot of air in the lungs, this is going to show up as hyperresonance to percussion when you tap on the lungs. And we said this is classically seen in things like air trapping conditions like COPD. And we can also see it in pneumothorax. And here, we don't actually have a lot of air in the lung tissue, but we do have a lot of air occupying that side of the thorax. Next, another very classic description is going to be decreased breath sounds. And often in question stems, they'll describe this as absent breath sounds, because in order to hear breath sounds, air needs to be going in and out of the lungs. But if the lungs are collapsed, then we won't hear any breath sounds on that side of the chest. Okay, so now let's move on to some X-ray findings. So the most classic X-ray finding that you're going to see is a collapsed lung, and you'll actually be able to see the lung collapsed, and the space that the lung usually occupies is going to just be completely black and air-filled. There's going to be no lung markings. And furthermore, in the case of a tension pneumothorax, so not in the spontaneous, just in the tension, we're going to be able to see a tracheal shift away from the affected side, away from that positive pressure. So let's just walk through a couple of these classic X-ray images here. We'll start with this one, which represents a spontaneous pneumothorax. So on this side, we can kind of see all these white lines. These represent lung markings, so we can see that the lung is intact on this side. Whereas on the opposite side, we see that these lung markings only extend about halfway through the lung field, and we can actually see this border right here. This is the border of the collapsed lung. And we can see on the other side of this border, there is no lung markings at all, and this is all just air within the pleural space here. And one thing I like to do whenever I'm given an X-ray image of a pneumothorax, and you'll be able to tell it's a pneumothorax because you'll see that collapsed lung with that darker airfield just outside the collapsed lung, is I always like to take a look at the trachea. So in this image here, we can see the trachea is this dark kind of tubular structure that lies in front of the vertebrae. And you can see that in this X-ray image, it's fairly midline, which for board examination purposes is suggesting that this pneumothorax is a spontaneous pneumothorax. So now let's take a look at this X-ray image over here, which represents a tension pneumothorax. And we can see on this side, we see lung markings that are extending all the way to the chest wall, which is suggesting that this lung is fairly intact. Whereas on the other side, we can see the lung markings only extend so far, and we can also see the border of the collapsed lung here. And we can see just exterior to this border, we have this black air-filled space which represents the pleural space that has accumulated air. And two things just to note here, we can see the trachea, which is this darkened tubular structure here. It is shifted away from the side of the pneumothorax, which is suggesting that this is a tension pneumothorax. And furthermore, we can see the heart right here, the border of the heart, we can see it's almost touching the chest wall. It too has been pushed away from the side of the tension pneumothorax. So now let's have a brief discussion on the management of a pneumothorax. So because in the case of a tension pneumothorax, we have the progressive buildup of pleural pressure. This is more of an emergency than a spontaneous pneumothorax. And so as a result, we need to perform something called an emergent needle decompression. And this is where we essentially insert a needle right into the pleural space and we are relieving the air from the pleural space. And so as a result, we are decompressing the tension pneumothorax. And lastly, another way we can manage a pneumothorax is by placing something called a chest tube. A chest tube can be used for spontaneous pneumothorax or a tension pneumothorax. And the idea is essentially the reverse of the unidirectional flap that has formed in a tension pneumothorax. So we are essentially installing a tube in the chest and it connects the atmosphere to the pleural space. And it is a unidirectional valve that allows air out of the pleural space but not in. So just taking a look at this diagram right here, let's say out here is the atmosphere and over here is the pleural space. With every breath, we are going to expel air out of the pleural space into the atmosphere, but of course, air cannot return into the pleural space. And so with every breath, we are going to be expelling air out of the pleural space in an attempt to relieve the pneumothorax. All right, and that's all we got for our video on pneumothorax.